on the topic hyperactivity and ADHD. As we all know, this is a very crucial and yes, a very burning topic of today's era. So, to address the very crucial topic, we have with us none other than Dr. Sujit Tamboli, sir. Sir has done PhD in developmental pediatrics, FIAP. He has done DCH, PGDAP, PGM PGD-MLS is a consultant developmental and behavioral pediatrician at the Chiranjeev Clinic. He is the founder and director of First Child Development Center in Maharashtra since 1992. So, has been the national chairperson of IAP Growth Development and Behavioral Pediatrics Chapter 2014 and 15. So, with this very brief introduction of Sir, now I would request him to please go ahead with the topic for today. Over to you, sir.
Thank you, Arpita. Welcome to Med Talks, all delegates. And we are going to see ADHD clinical diagnosis management and hyperactivity. So actually, we will start with case. It's not moving. We have a one case where the I have got a note from the parent that respected parents, your child is not behaving normally in the class. He pokes with the compass to other children, beats teacher from behind, not attentive in class, and he doesn't feel guilty about that. So that was the problem. Means he was very hyperactive, but he doesn't feel that he is doing something wrong. So, what is the definition of ADHD? It is a neurological condition that involves problems with inattention, hyperactivity, and impulsivity that are developmentally inconsistent with the age of the child. So, prevalence is 6 to 10%. That is very important. So, more prevalent in the male than female. So, male female ratio is 3 to 1, and 50% of children referred to child development clinic are referred for the ADHD related problem. But inattention, impulsivity, and hyperactivity are the tip of iceberg. 30% they develop developmental delay. There are sleep disturbances, poor working memory and recall, poor judgment of time passing, slow math calculation, disorganization, impulsive learning style, repeats misbehavior, and difficulty in regulating mood, emotions, and behavior. So actually, what are the genetic factors for this? Twin studies indicate that disorder is highly heritable, and there are around 75% factors are in ADHD cases as a heritable. So that ADHD doesn't follow the traditional model of a genetic disease, but a complex interaction among genetic and environmental factors are important. So to date, no single gene has been shown to make a major contribution to the ADHD. Then what are the possible developmental pathway for ADHD? There is genetic risk, environmental factors, the disturbances in the dopamine transmission, failure to adequately suppress in appropriate response, abnormalities in the frontal lobes and basal ganglia, then failure to adequately suppress inappropriate responses, cognitive deficit in the working memory, self-directed speech, and self-regulation. So then, actually, that causes again behavioral symptoms of inattention, hyperactivity, impulsivity. Then impairment in social and academic development, disruption in parenting, oppositional and conduct disorder. So what is the etiology? So to summarize that, it is due to the genes and environmental factor or brain injuries and dietary factors. So actually here environmental factors are also very important. Then what are the early pointers to ADHD? So in toddlers and preschool children, they present as hyperactivity. So parents or teacher complain that they are always moving, being on the go, changes the focus of activity frequently, appears to be without purpose or goal, marked clumsiness, accident prone. So example is that frequently leaves table during the meal, cannot sit still while listening to a story, in continuous state of motion even when watching television. So what is the typical toddler hyperactivity versus ADHD? So we can see one case where 4-year girl was referred from the school, doesn't sit, hits and pushes children, doesn't like pre-writing activity but seems to know the answer. So tantrums at home. So what it could be? History, normal baby, term normal 3.2 kg, family history there is no problem, non-consanguineous first child, no family history of any psychiatric illness. Developmental history, there are problems in the motor skills. That child has skipped crawling, fine motor, uses both hands still. ADL, that is fussy about food and can remove her pants itself. Communication, words after 2 years, but now sentences, behavior, tantrums, hits and pushes children. So hyperactivity versus ADHD, are all hyperactive children are suffering from ADHD? A definite answer is no. One can only diagnose ADHD after fully meeting the DSM-5 criteria and after a detailed evaluation which fails to point to other conditions which mimic ADHD. Some kids are normally hyperactive with a very short attention span and some more so than other. So actually, it is a neurobehavioral disorder and maladaptive level of impulsivity, hyperactivity, inattention in more than one setting. This is very important that it should be more than one setting. Means if the child is hyperactive in the school and may not be hyperactive in the house, then it may not be ADHD. So or vice versa. Means child is एकदम quiet and good boy in the school, and then if the child is having some problem in the house only, so that is not hyperactivity, because many times such children are normal. So appropriately occurring behavior, that occurs inappropriately more frequently than behavior in the most people and occur to extent significant dysfunction. So what are the differential diagnoses for this? Autism spectrum disorder, hearing loss, developmental delay, sensory processing disorder, LD, that is learning disorder, seizure disorder, developmental coordination disorder, or anxiety, or environmental stimulation, school setup problem, then medical conditions like school absenteeism. What are the early development of ADHD? So actually, American Association of Pediatrics now extended their guidelines for the diagnosis and treatment of ADHD to age of 4 years. Means previously we used to diagnose ADHD at 7 years of age, but now it has been reduced to 4 years of age. So 75 to 89% preschooler show high level of ADHD. And ADHD under 3 years of age is associated with externalizing disorders such as overactivity, defiance, and tantrum. So, fidgeting or difficulty in organizing are sensitive symptoms which can predict ADHD. Low birth weight and prematurity are the risk factors for ADHD. Early intervention and parent training programs are very important. So, what are the early markers of the preschool child? Maternal ADHD, maternal anxiety, maternal depression, pre-pregnancy risk drinking, or perinatal morbidity, or birth weight, or decreased gestational age, or gender, socioeconomic status, birth asphyxia. Then toddlers as a medical and neurological status with lower attention and higher activity, or increased neonatal morbidity. So all these are, we can call it as early markers for the preschool for the ADHD. Then, what are the predictive factors from toddlers to adolescent? It's anatomical and physiological changes in the basal ganglia structure, imbalance in the corticostrial intrinsic functional connectivity. Dopamine neurotransmission is dysregulated, which causes restrictive repetitive behavior. And restrictive repetitive behavior predicts severity of the inattention symptom. So, severe restrictive repetitive behavior and low adaptive skill predicts severity of hyperactivity and impulsivity symptoms. So lower communication adaptive skills are very important, and we can reduce the restrictive repetitive behavior level targeting adaptive skill deficit as early as possible and will improve the severity of the ADHD symptoms. So that is important, that how we can reduce the ADHD symptoms if we diagnose it early. Then psychometric properties of ADHD symptoms, that child may fails attention to details or difficulty in sustaining attention, does not listen, no follow through, difficulty in organizing, avoids sustained effort, loses things, easily distracted or forgetful. Then hyperactive and impulsivity symptoms like fidgeting, leaves seat, runs about, difficulty in playing quietly on the go, always on the go, talks excessively, blurt out answers, means actually before asking full questions, their answer is ready. So difficulty in waiting turn or interrupts or intrudes. So correlation between behavioral problems and ADHD is very important. Reducing externalizing problem will improve ADHD symptoms. Proactive and positive parenting is a significant independent predictor factor of child problem behavior. So, what are the myths and misconception about the ADHD? Most parents are under the impression that ADHD is a problem only in the school age children. In fact, the symptoms of ADHD and diagnosis of the condition can occur even in the preschool age group. So, when hyperactivity and impulsivity gets to a point where they are significantly and consistently interfering with the preschool's life, development, self-esteem, and general functioning, it may be labeled as ADHD. So it is important that it should affect at least two areas and it should affect their performance. So that is very important. So appropriate intervention is very important. Then again, one myth is that he is just lazy and unmotivated. So many parents says no, he is not ADHD, but he is just lazy. He doesn't want to do that. No child fails on purpose. So nobody wants that I should fail in the exam. So all children want to succeed and get praise from for their good work. But if a child is not doing well in the school, there has to be a cause, and it is our responsibility to find it and, if possible, provide remedy. So these children find it nearly impossible to stay in the class or complete a lengthy assignment. Such children may act as through they are lazy to save their face. If these children were to be helped to succeed, then they should be motivated like other children and give these children shorter and doable assignment and let them succeed. So their assignment should be shorter. My child can focus on his video game for hours. So how can it be ADHD? So here, most important thing that in video games, the number of frames are almost 200 per minute, which provides a continuous stimulus to the child to continue the game. So most often children get a diagnosis of ADHD in their school years precisely because of academic, social, or behavioral demands during these years are overwhelming for them. And these children fail in activities which need high degree of focus, concentration, ability to sit still, and need to wait for their turn. So actually when to refer? So wait and watch if it is a recent or inconsistent, appears as a single place or time, occurs primarily during group time when prolonged sitting is required, indicates child is acquiring skill, and refer when observed for more than 6 months, when it is a problem of several settings, occurs during independent and group activity, and cannot be explained by other circumstances. Disability means actually all other disabilities are ruled out and still hyperactivity is there, you must refer. And it interferes with learning. So if it affects poor relationship and social development and is inappropriate despite clear, consistent age appropriate expectation. That is very important. So another case we can see that now a 8-year-old boy presented with difficulty in sustaining attention, gets distracted, slow at all tasks, and has difficulty with writing, refuses to read, hopeless with the numbers. All complaints persistent since play school and is on the increase. So here again, all history is uneventful, and there is slight delay in all milestones. Significant speech delay, first word by 1.5 year to 2 year, and two-word sentence by 3.5 years. IQ is 60. So investigation, no medical screen or brain imaging technique, relevant investigation, typhoid function test. पेशंटला तिकडे वरती बसायला सांग. Typhoid function test and blood level, lead level may be carried out if suggestive features are present. Hemogram or serum iron level, evidence-based assessment, screening, parent screening and structured clinical interview with the parents, IQ achievement, child behavioral observation at home and school, no medical screen or brain imaging technique. So ADHD screening and diagnosis is very important. How we can diagnose them? With screening of surveillance of the ADHD involves parent-teacher questionnaire, Child Behavior Checklist, that is CBCL, Connors or Vanderbilt. The above three stands out as the most reliable screening or diagnostic test for the ADHD. So actually, Indian children here incline diagnostic tool is also there, and guidelines which are adopted from the AAP, that to make a diagnosis, pediatrician should determine that diagnostic criteria have been made from on the basis of the DSM-5 criteria. So what are the DSM-5 criteria? Either six or more symptoms of inattention and or hyperactivity and impulsivity and onset before age of 7. It is all these symptoms are persistent more than 6 months. Impairment in at least two settings. So impairment may be in a social, academic, or occupational function. So out of these three, two settings there should be abnormality or impairment. So no other psychiatric disorder. Even in adolescent and adult, actually new change in DSM-5 has been done, that all these symptoms can be seen even in adolescent as well as adults. So we can, if the symptoms are there and if the diagnosis is to be given in the adolescent, it can be given if the symptoms are there. So DSM-5 symptoms: inattention. What are the symptoms? Carelessness, difficulty sustaining attention in activity, doesn't listen, no follow through, cannot organize, avoids tasks, loses importance items, easily distracted, forgetful in daily activities. Then hyperactivity symptoms like fidgeting, cannot stay seated, runs or climbs excessively, cannot play quietly, on the go, driven by a motor, or talks excessively. Impulsivity, symptoms like bursts out answer or cannot wait turn or intrude or interrupt others. So here, very important to remember that presentation of DSM-5 criteria should be diagnosed, and ADHD are three types, like predominantly inactive, inattentive, or predominantly hyperactivity and impulsivity, or combined type. Here, important to remember is that impulsivity and hyperactivity goes down as the child's age passes. So in adolescence age group, you may not get impulsivity and hyperactivity more, but you may get more of inattention. So that is very important to remember. Then what are the complications of ADHD? There are academic problems, obviously, then social problems, fear rejection, criminal activities, inferiority complex, or disturbed family. So all these should be taken into consideration. I think we will not go to the cases because of short of time. Then ADHD comorbidities, what are the differential diagnosis? Learning disorder is very important, which is around 50% cases it is commonly associated. Then autism spectrum disorder, mental retardation, movement disorder, epilepsy, hyperthyroidism, drugs, substance abuse. So all these are important factors. So when the professional help is needed, the behavior must appear before 7 years of age, and it should be continued for 6 months. That is very important factor. We have seen before also. So actually, the symptoms may be present in at least two of the following areas: in the classroom, playground, at home, community, or in social setting. So now we will see the management of ADHD. Medications do not cure. They control the symptoms for as long as they are taken. ADHD can persist into adulthood, but usually symptoms gradually diminish. When it persists into adulthood, it usually requires ongoing treatment and counseling. So how to treat? With the medication, you have to advise behavior modification or combination of both, and treatment of comorbid condition. All these factors are very, very important. That medication alone will not help, but medication are important, and in ADHD you have to give medication. If it is a ADHD, without behavior medication, patient will not improve. With the only behavior modification or counseling, patient will not improve. So you have to give both medication as well as behavior modification, and treatment of comorbid conditions like learning disorder or whatever other symptoms, other conditions we have seen just now. See, again, I will show you this learning disorder or epilepsy or hyperthyroidism. So all these associated comorbid conditions also should be treated. So actually, medications, which medications we use, either methylphenidate or dextroamphetamine or atomoxetine or low dose antidepressant. Behavioral interventions are behavioral parent training, behavioral classroom management, and intense summer treatment program. So what are medication? When to start, how to give, how to monitor them, how to stop them. All these are important. So in this chart we have given. So suppose methylphenidate. So your dose should be 0.3 to 1 milligram per kilogram, and it can be given OD dose or BD dose. It's not very regularly as a TDS dose, but it can have problem of headache, nausea, insomnia, or it can affect growth. Then atomoxetine is again common, we use. So it can have a side effect of anorexia, dizziness, or irritability, and dose is zero point 0.5 to 1.8 kg milligram per kg OD dose, and maximum is 80 milligram. So methylphenidate, we will not go into the details of any of these medicines because they have side effects. Whatever are there, they are not very common, but you have to actually you should know what are the side effects of the this thing. uh, then medicine. So combination treatment is very effective. What is combination treatment? That is medicine as well as behavioral modification. So behavioral modification, what is there? That is basic principle is that antecedent, behavior, and consequences should be taken into consideration. Routine schedule should be there. So there should be structure environment. At certain time, certain things to be done. Developing social skill, turn taking, communication, instruction should be understood, and positive reinforcement should be given. So antecedent is child is working, gets up and runs, and consequence can be avoid work. So here it is very important that we should monitor their work, what is the behavior, and then we should guide them accordingly. So what are the techniques which can develop their behavior? There are these techniques we are doing in our center with our counselor, that behavior modification technique or types of rewards, shaping, chaining, prompting, punishment, or modeling, or self-management instruction. So psychosocial support is very important. Family reaction, role of the parents, effective teacher, which are there for the child who can manage their learning disability, role of general teacher as well as resource teacher. Then peer sensitization, role of peers is also very important. So what I can do to help my child is the always question by the parents. So actually you can advise them, make a schedule, make simple house rule. It is important to explain that actually the rules should be obeyed, and when they are broken, write down the rules and the results of not following them. Make sure your directions are understood. Reward good behavior. Make sure your child is supervised all the time. Then teaching in specific areas, like reward the student, actually make him monitor of the class. So give classroom privilege, established routines for placing object or especially routinely used objects like books or assignment. Then point out to the silent features of assignment. Provide the student with a list of material which is needed for each task. Limit the list to only those material necessary to complete the task. Then enhance the clarity of instruction. So repeat as often as calm and clear tone. Shorten the task by breaking one task into smaller part to be completed. Then make task more interesting. It should be in a game format, and it should arouse interest in the child. So watch your child around his or her friends, reward good play behavior, set a homework routine, focus on effort, not grades. Talk with your child teacher. Will the child outgrow ADHD? This is always question asked by the parents. So natural progression, motor component goes down, but attention deficit stays. Result depends upon the IQ level. There may be actually ADHD in engineer, doctors. I have seen many in professor also. So comorbid condition, keep it keep up with their self confidence. Children with motivated, supportive parents have the best chance. So, natural history is very important. The symptoms may remit at puberty or persist into adolescence, and it is related to degree of persistent comorbid conditions like psychopathology, especially conduct disorder or social disability or chaotic family. So, no rule in the family, no proper communication in the family. Food, actually, artificial food color should be avoided because they can cause hyperactivity. So it is very important to go through the food standard agency and avoid that food. So dietary advice is elimination of the artificial coloring and additive from the diet is not recommended as a routine treatment, but it can be avoided they can definitely improve their hyperactivity. Some children with ADHD may respond to dietary intervention, including removal of food coloring. So management of associated problem like specific learning disorder, ODD, conduct disorder, anxiety and depression, and epilepsy with the use of anti-epileptic drugs. So child abilities are more important than his disability. Our goal should always be to open doors for the child, not to close them. So to summarize, ADHD is highly prevalent brain-based disorder, which is associated with lifelong impairment in the functioning. Environmental factors can contribute to the expression, severity, course, and comorbid conditions. Stimulant medication and behavior therapy are useful for the management of ADHD. So thank you very much for your patient listening. Thanks a lot.
Thank you, sir. Thank you so much for beautifully projecting the
If there
topic.
are any questions, I will like to answer them.
Right, sir. Right, sir. There are two, three questions.
Yeah.
Um, One question has come from Dr. Sumati Balaji, wanted to know about the medical conditions associated with ADHD, which I think sir has already discussed. So related to that, there is another question that is, how do you tailor the ADHD treatment plan for patients with have coexisting conditions such as anxiety, depression, or learning abilities?
So it is very important that we should diagnose them different all these conditions. That is very important, and that can be diagnosed with the standardized test, psychological standardized test. So with that test, if you diagnose in some child that that child may have normal IQ, but may be having ADHD, may be having anxiety, may be having depression, so or learning disorder, whatever is there, so then we have to treat every part of that illness. Suppose you are treating ADHD, it will not get sufficient, child will not improve. But if you manage with the behavioral therapy as well as treating their anxiety and depression, then child will definitely improve, and then his ADHD symptoms will also decrease. Okay.
Thank you so much, sir. Another query.
uh,
Sir, can you please briefly just discuss the long-term outcome for individuals with ADHD and hyperactivity, and what the strategies that can be employed to support them through different life stages, including adolescence and child adulthood?
Yeah. I've already told that in ADHD, actually, what happens that hyperactivity and impulsivity that goes down in the adolescent period, but inattention remains. So what you have to do is that support them in that area where they are lagging. Suppose inattention is there, then how to improve their attention. So it can be done with the counseling as well as behavioral technology, behavioral methods also. So with behavioral methods, we can definitely improve their inattention part.
Right, sir. So these were the questions. Sir, thank you so much for giving us your crucial time, and thank you so much for putting light into the topic. I would like to thank all the audiences for joining in and making the session successful one. Thank
Thank
you
you.
so much once again for putting your time. Thank you. Thank you, sir.